Visit our website on Teachable, our YouTube channel. Sign up now. Let's make your success story the next one on our list. Preparing for the MRCP PACES exam can be a daunting task with so much information to learn and remember. It is easy to feel overwhelmed, but it doesn't have to be that way. And now, we want to help you too. Dr. Tan has been teaching PACES for 7 years, and he has helped over 1,000 students pass their exams. Our course is called Dr. Tan Algorithmic PACES, and it's the best reviewed online PACES course out there. We use algorithms and mnemonics to help you remember the approaches for every case you will face on exam day. With our materials, we simplify PACES for every candidate, even if you're starting from scratch. And because we know you're busy, we give you access to the recording of every lecture on Teachable for 1 month, included in the interactive course price. We'll practice more than 100 cases and more than 35 algorithms and mnemonics over 12 days, including the most recent cases that have appeared in all the testing centers in recent years, and you'll get the chance to practice with Dr. Tan, one-on-one. You'll be practicing in the new PACES system, and you will learn the approaches for every case you might face in PACES. And it also includes a full explanation of everything you need to know about the neurology systems. You will also get printable slides to be your primary source for exam preparation, without having to waste your time on multiple sources. But seats are very limited, so if you're serious about passing the MRCP PACES exam, sign up now and join the more than 1,000 success stories we've helped create. To join our course, contact us on WhatsApp on these numbers, and also visit our website on Teachable and our YouTube channel. Sign up now. Let's make your success story the next one on our list.
Assalamu alaikum. This is Dr. Tan. Please confirm in the chat box that my voice is clear. Can anyone confirm on the chat box, please? Okay, great. So we will allow 100 attendants today because last lecture last week, they told me that we were unable to join. But anyway, I think there's a problem. Okay, if you can please share the link of the lecture in the groups so we can collect the 100 before we start practicing the case. Sorry for the late announce, by the way, because I was not sure that I will be available. Today we have Dr. Hina and we have Dr. Rufaida. Maybe Dr. Hina, if I'm pronouncing the name in the right way.
Yes,
Dr. Hina.
hello. Yes, Dr. Hina Umar.
Assalamu alaikum, Dr. Hina.
Wa alaikum assalam.
So tell us about yourself. MRCP, MRCPI.
MRCP PACES UK. I'm appearing in January in Pindi, Rawalpindi Center.
Okay, great. And so, okay. Dr. Hina will take the first case, and today we will practice 2 important cases. Both appeared in the last diet. The first one will be the long case, clinical consultation, and the second one will be communication. I think Dr. Rufaida will be practicing this case. Dr. Rufaida, are you here?
Yes, I'm here. How are you?
Hi, Dr. Rowan. How are you? Dr. Rufaida. Yes, so you'll practice the second case. Okay?
Okay.
Okay. So any question for me before we start? Let me start sharing my screen. Okay. The communication case is very interesting today. It was very confusing for some candidate in the exam. So that's why I decided to practice this case with you. Just announce we're going to start our course on December 2nd, Saturday, the interactive limited seats. So if any of you are planning to attend our interactive course, it will be interactive online, so we'll be practicing live cases. If you're planning to join this course, please contact Dr. Mahmoud on the number I will share on the chat. And if you're planning to join our recorded course in Teachable, also ask Dr. Mahmoud about that. And if you plan to join, please try to join a little bit earlier, because we'll send you a link to access Teachable, even the interactive course, so you can watch some lectures before we start. So please don't wait until the last moment and then ask me to join, because I won't be able to help you with that. It said internet is not stable. Okay. Just a second, let me. Okay, Dr. Hena.
Yes,
Hello?
doctor. Yes, yes.
Just a second. Doctors, can you please close your cameras? I don't know why the cameras are opening. Some doctors opening their cameras. Maybe this. There should be an option to not allow cameras to open. Okay. Share the link for what, doctor? Okay, just a second. Okay. Dr. Hanna, can you see the scenario now?
Yes.
Okay, so this is Mrs. Basma Thompson, 39 years old, and you are the medical registrar in the general hospital. And as you know, you have 15 minutes with the patient, and the examiner will alert you when 13 minutes have elapsed and will stop you after 15 minutes. The remaining 5 minutes, one examiner will be examining you. You will report any abnormal physical signs and your diagnosis or differential diagnosis. Okay, and the plan of management. The clinical problem today is not that much information inside on the scenario, but there's much information inside. So you are a medical registrar in the general hospital. Your next patient is a 39 years old lady who present with complaint of headaches. That's it. Please take a focused history and perform a relevant examination to determine the likely cause of her symptoms. You will have 15 minutes for the station. Usually in the exam, you might see some clinical vital signs, okay, or more clinical information. But anyway, I just want you to be prepared to dive deeper in the details while practicing the case. So I will give you 3 minutes, doctor, then to put your plan, then we can start, okay? Okay, doctor? Dr. Hannah?
Yes, yes, doctor. Yes.
Okay. We start the timer again. Okay, doctor, you can start.
Hello, my name is Dr. Umar, one of the medical registrar in the hospital today. Am I speaking to Mrs. Bisma Thompson?
Yes.
Okay, just to check with your identity, can you tell me your age, please?
Yes, I'm 39.
Okay. How should I address you during our conversation?
Call me Basma.
Okay. So, Mrs. Basma, I've gathered from your notes that you have a problem with a headache. Can you tell me more about it?
Yes, doctor. I used to have some headaches, but
Mm.
in the recent, then in the last 4 or 5 months, I start to have these persistent headaches, and it doesn't respond to the regular painkillers I used to use to relieve it. So I start to be very worried about that.
So 4 to 5 months you have a persistent headache. I'm so sorry to hear about your problem, Ms. Bisma. Hopefully at the end of our discussion, we'll be able to sort some solution for your problem. So before this 4 to 5 months, you told me that you used to have headaches. It means that previously, before 4 to 5 months, you had headaches also?
Yeah, I used to have some headaches happening when I come back from work, when I don't sleep well. But this headache was used to respond to taking some painkillers.
Mm-hmm.
Mhm. But
Okay.
this one I'm feeling now is more severe and it's more persistent and
So you feel that this is a different type of headache that you used to
the
have
regular
before.
pain I use.
Hello, Mrs. Basma. So you think that this is a different
Yes,
different
that's what I
headache that
feel.
you
Yeah.
used to have before?
Yes,
Okay. Can you tell me where exactly this
yes,
headache
doctor.
is? Can you tell me where exactly this headache is? Hello.
Usually I feel it. Yes, I feel it in the front of my head and sometime in the whole head.
Okay. Um, and may I know, it is sudden or gradual in onset, that 4 to 5 months?
Yeah, it was mild in the beginning with less frequency, but now it's more frequent and more severe. So I would say it is increasing in frequency and in the severity.
Hmm. I'm so sorry to hear about it. So if I ask you, one is the less severe and 10 is the maximum, how should you grade it out of 10?
Sometimes I would say sometimes it's 6 or maybe more.
Mm-hmm. Okay. And does it radiate to anywhere?
I feel it in my eyes as well.
Mm-hmm. Okay. And how does this pain looks like? It is a dull pain or it is sharp stabbing pain? How you describe it?
I can describe it as dull.
Mm-hmm. Okay. And is it getting worse with bending, coughing, or sneezing?
Recently, yes, I start to feel that, yeah, it's increasing while I'm praying or leaning forward to do something.
Mm-hmm. And what makes it better?
Um, Nothing specific recently, but I'd say with some rest and laying down, I feel a little better.
Okay, rest and laying down.
Yes,
Okay.
little bit.
Um,
Mhm.
so if this headaches last, for how long this headache last? Once this episode starts.
Now I would say it can extend for hours and sometimes the whole day.
Hmm. Okay. And this comes and goes. How many times you get an attack, like in a day or in a week?
And as I'm telling you, now it's every day, almost every day.
Hmm. Is it worse in the morning or throughout the day? Any specific time?
It's present all over the day, but I would say yes, it's more in the morning.
Hmm. You told me you have problems. It goes into your eyes. You have any vision problem with this?
Yes, I start recently to feel blurring vision as well. I feel like my vision's not as I used to have.
Hmm. What do you mean by it? You see double vision or you see blurred vision?
Blurry.
Both eyes or one eye?
I think both eyes.
Hmm. And is there any the problem with the watering of from your eyes or anything like this?
Sometimes I feel like some redness
Hmm.
and some watering from my eyes.
Okay. Do you have any weakness in any part of your body?
No, doctor.
Any numbness, tingling in any part of your body? Hello?
Yes, doctor. No, no, I don't have.
Okay. And apart from this, do you feel like there is any problem with the gait and balance?
No, doctor.
Okay. Do you have any history of any blood disorder like clots or something?
No, doctor.
Any bleeding problem in?
Bleeding, no, doctor.
Okay. And apart from this, Mrs. Basma, what about your weight? Is there any change in the weight?
Weight, no, doctor.
Okay. Appetite?
Appetite, now I don't eat as before because I feel most of the time like I'm sick.
You feel like throwing up?
Yeah,
Mm-hmm. Do you have any lumps and bumps?
no,
Any raised body temperature?
no,
Any neck stiffness?
no.
Okay. And apart from this, is there any problem with like cough?
Cough, no, doctor.
Okay. And apart from this, do you have any family history that I should be aware of?
Nothing specific, doctor. My father is hypertensive and my mother's diabetic.
Okay. And any past medical history that I should be aware of?
Uh, Generally, no. I used to be healthy.
Okay. Are you taking any kind of medicines?
For headaches, I tried many of over-the-counter medication.
Okay. And they are not helping you?
No, doctor.
Hmm.
And I'm also using a medicine for my for a skin problem.
Okay. Can I, no, can you show me your drug list, like your medicines, which are you using?
I'm just taking tretinoin for the acne on my face.
Mm-hmm.
Mhm.
Okay. Apart from this, do you have any, can I ask you about your cycles? Are they regular?
No, doctor. They're very irregular recently. Recently, in the last few months as well, my cycle is very irregular.
Okay. And when is your last period date?
Uh, it was 1.5 months. It's on and off, but it's very irregular. I used to have regular one.
Mm-hmm. Mrs. Basma, can I ask you some personal question if you don't mind?
Yes, sure.
Is there any, by chance, are you pregnant?
Pregnant? No, no, doctor.
Mhm. Are you using any birth control?
I was unable to get pregnant actually. We were trying to make a baby, but
Mm-hmm.
it wasn't successful in the last year.
Mm-hmm. And so, any history of miscarriages in the past?
No,
Okay. You told me there is no weight changes, right?
no weight change.
Any weather preference?
No, no.
Okay. So this blurring of vision is constant or it comes and goes?
I lost you, doctor. Can you check your mic? I can't hear you.
Hello?
Uh,
Hello?
yes,
Yes, I'm
yes,
asking this
doctor.
blurring of vision is constant or it comes and goes?
It comes and goes, but recently also it is increasing. Most of the time I have the blurring.
Okay. Do you feel any tiredness or fatigue?
I'm not as before. I'm not as usual.
Okay. Any weather preference?
No,
Okay. Apart from this, do you have any surgeries done in the past?
surgeries? No, doctor.
Any change in the sleep pattern?
No, doctor.
Okay. So you have not consulted any woman doctor regarding your pregnancy?
We were planning to go to a doctor maybe next
Mm-hmm.
month. Mhm.
Okay. And do you have, are you already allergic to any medicines?
No, doctor.
Okay. Uh, Apart from this, do you smoke, Miss Basma?
Yes, doctor.
Okay, how many cigarettes and for how long?
Around 15 cigarettes a day since 10
Okay.
years.
And are you taking any alcohol?
No, doctor.
Okay. Any party drugs? Sorry to
No.
ask you. Okay. Miss Basma, I want to examine you. Is that okay?
Sure, doctor. What do you want to examine?
Yes, I want to check your vision first.
My what? Vision?
Vision.
Okay.
So I would like to I will make an H since she's complaining of blurring of vision also. So you don't follow my finger without
So you
moving your
will
head.
just, doctor, you can just say, I'm going to check the visual field, right? This is what you want to do?
Yes.
Okay, visual field.
Mm-hmm.
Okay. No abnormal finding.
Okay. Now I'm asking her to, I am checking for ophthalmoplegia and any double vision. I am making an H in front of the eye. Please follow my finger. And if you see double or any pain, please let me know.
Mhm. Okay, no double vision and no nystagmus, but there is diminished visual acuity.
Damaged?
No, visual acuity diminished, reduced.
Oh, okay. So fine. If I
Two
ask,
minutes, two minutes remaining, doctor.
okay. Can you raise your legs one by one?
My legs.
Hmm?
Yes, I can, doctor. No weakness
And can
abnormal.
you raise your hands?
Yes, doctor. No
Okay.
abnormal.
Can you show your cheeks?
Yes, normal.
Okay. Quickly, I would like to auscultate her epics if
Yeah, normal.
okay. And the pulse is normal, both
Yes,
sides?
yes.
Okay.
Two
Ms.
minutes
Basma,
remaining.
do you have any concerns?
Two minutes remaining. Yeah.
Do you have any concerns?
Yes, doctor. I start to be very worried about these headaches because one of my friends what was recently diagnosed by cancer, brain cancer, and they discovered that it's a very late stage of cancer. So I'm very worried about that. And my other question is about our inability to make a baby. I don't know if there is something can help. I don't know, maybe this headaches is related to this issue. I don't know. I read something on the internet and I need your advice.
Mm-hmm. Mrs. Vasma, after taking your history and after doing your examination, I currently I don't think so that there is a cancer, but there is a possibility. And while we are going to investigate you, definitely we will keep it in our investigations list in our workup. Any other concerns?
Yeah, I told you, doctor, is that related to my inability to become pregnant? Is there something? Is there a link with that?
Well, there could be a possibility, Mrs. Basma, and
Okay, so
there
what's my problem?
definitely.
You didn't tell me what's my problem, doctor. What do you
Yes,
think the reason of my problem?
it could be because could be some hormone balance, or there could be some bleeding disorders could be there.
Okay,
That's why you're
time,
having.
time, finished, doctor. Thank you, Dr. Hanna. And now you have 5 minutes with the examiner. Then we will discuss. Okay, doctor, what is your differential diagnosis for this patient?
This lady is complaining of headache, which has been worst for the past 4 to 5 months, and it is
Mhm.
in the front, and sometimes it is in the whole head, and it is radiating to the eyes as well. There is blurring of vision, which comes and goes. She is telling me. Uh, I cannot
What's your
find any.
differential diagnosis, doctor?
Okay, so my first differential could be some could be some clotting problem, some antiphospholipid syndrome, or some she's having some PCOS.
What the signs you found for antiphospholipid syndrome?
Actually, she's telling that she's having problem with the pregnancy and she's
Is
taking
there any
tretinoin.
recurrent
I
abortion
was
and
thinking
skin
initially I
rash?
thought could be idiopathic intracranial hypertension, but she's not gaining weight, though she is using this tretinoin, which can worsen this pain.
So
Um,
it's intracranial,
Hypertension.
idiopathic intracranial hypertension. This is one
Yes,
of the
but there
differentials.
is no history of weight gain.
And it can't happen without history of weight gain, right?
As far as I know, there should be weight gain. There should be a waist weight, and there she's
So
not having.
this exclude having no weight gain clearly excludes the possibility of
But she's telling at the
idiopathic.
same, maybe she's telling that she's not eating less, and she's having complaint of irregular cycles, and so
What else can be the cause of headache, blurring of vision, and irregular menstruation?
I was thinking some antiphosphate, but there is no joint pain, no rash.
Did you ask these questions?
I think I didn't ask this.
Okay, what else? What else can be the differential diagnosis?
It says could be some space occupying lesion because she's telling that she's a dull pain and
Such
it is in
as,
the morning.
yeah, what type? What type of space occupying lesion you think about?
Could be some pituitary tumor is there, but if
Did
it
you
is
ask?
there, then because she is complaining of low, I mean irregular cycles, so could be some non-functioning adenoma is there.
Non-functioning adenoma?
But there was no temporal loss of vision. She was complaining of only blurring of vision.
Should it be there all the time?
Yes.
You mean having no temporal affection of the vision exclude the possibility of pituitary adenoma or pituitary tumor?
Well, it is not necessary if it is tumor is not as big, which is causing compression. So it's not necessary.
Okay, what do you expect to see? This patient, do you think this patient had signs of increased intracranial pressure?
Yes, he told me he's having bending forward is he's getting more pain, and it is dull in
Okay.
nature,
So you
and it
think
is shorter mostly.
yes or no, doctor? You
Yes,
think
yes, yes.
okay. And what do you think you missed in examining this patient?
Actually, I got a very less time. I could have asked her if she's not told me any hypertension, and there was no.
Examination, doctor. My question is about while examining the patient.
Mhm.
What do you think you missed in examining the eye of this patient?
Fundoscopy,
What do you expect to find?
papilla edema, if there is high raised intracranial pressure.
Thank you, doctor. Time finished. Thank you, Dr. Hannah.
Mhm.
You felt stressed?
Yes, at times I was thinking, what is happening with this lady?
Okay. I know that everyone listening got the diagnosis or a listed differential, but yes, when you are out, it's easier, right? When you're not the one practicing the case, so it's very clear, but when you are inside the case, it's more difficult. So I understand your stress, doctor, and what we will discuss today will help you to be more organized and not to miss anything, okay? I would say you did well. You need some more good utilization of the time. You started examination very late. Okay,
Mhm.
I will just read the points. What you did well is confident. You were confident. You asked a good, very good analysis of the complaint, but more than needed. I don't want you to ask questions without knowing what you will do with the answers. So it's very important to be a little bit quick. The most important thing I wrote in my paper about your performance, that you need to be faster and you need to be more targeted. You need to know why I'm asking this question, okay? One more thing, the empathy and sympathy. Please, everyone, focus that now you are evaluated in this station for communication as well. So if your communication skills were not good in the long cases, beside unsatisfactory or borderline performance in the communication stations, you might fail this skill. And you know, in the PACES exam, if you failed one skill, you will fail the test, even if you got 160 over 168. Okay. So please focus that you are evaluated for the communication skills in these cases as well. Okay. Because they collected the station 5 communication part and history communication part and put it in 2 cases where you will be evaluated. So the sympathy and empathy, I didn't feel you for 1 second to ask that you're sorry for what the patient is suffering. You didn't ask her anything about how this headache affects her life, right? Do you know even what's her job? Do you know if she's married, living with someone? She got any support? Don't you think these things are important? Do you know the skeleton of the cases in general, whether the long cases or the history or station 5 that we used to have before, which
Doctor,
is the
actually, I'm facing problem. My history gets lengthy, and it usually
yeah.
reaches 10, 11 minutes. And by the time it reaches to examination, I am not able to address the concerns. This is my biggest weak point.
Exactly. That's why with some practicing, you will first omit the long details you asked about. You spend 7 minutes, keep repeating the question about more and more details about the complaint itself. If you are thinking if you have approach, if you have like a map in your mind to go through, this won't happen because you will save a lot of time and you will have time for what we call the structure. If you attend with us the lectures before about the structure of the case, you can't go outside this case without asking menstrual history very early, because you asked about my cycle very late. Okay, and this will give you many answers. Okay, we said this case is most of the doctors in this differential. Please, doctors, write in the chat box your differential for this case. If I asked you the question of what's your differential, so give me 2 or 3 accepted diagnoses, because this is how you get the marks, Dr. Hanna. You need to give reasonable differential diagnosis list, including the correct one. Okay, so this is what you need to provide the patient, the examiner with. So this is one thing. So please, doctors, write in the chat box, what do you think the differential diagnosis or diagnoses are? Okay, sympathy and empathy, Dr. Hannah, I wrote a comment about that as well. You need to be sorry for what the patient is feeling. You need to show understanding. You need to ask her about the impact of that in her life and his job. Okay, it's very important. I wrote also very late examination, and when she told you about the acne, you need to dig deeper about the other things related to increase the intracranial pressure, including if she's taking anything other than the tretinoin as well. Since how long? How long she's taking the tretinoin? Show the examiners that you catch something. Okay. You just said, okay, you went very fast across that. Okay. The vision, you missed examining the fundus, which is a very important thing you missed. And I think you might lose this station without examining the fundus, unless the examiners were very nice. And the social history, I wrote that you didn't ask for the social history or travel history or sexual history, and all these are important. You didn't ask about fever as well. Fever is very important in the cases of headaches.
I asked
So
about fever.
you asked about fever?
Asked about
Okay.
fever, yes.
Yeah, maybe I missed that. Okay. So anyway, when we go now through the algorithm we use for headaches. Did you watch this before? Did you watch any lecture of our algorithm for headache, Dr. Hanna?
Yes, I watched once.
Okay, and do you remember that we went through the left side and the right side and all these details? Do you remember that?
I remember first you told me to rule out this raised intracranial
Yeah.
pressure headaches by
Mhm,
asking,
mhm.
mm, and for
Okay.
fever and
Yeah,
meningitis.
if you did that earlier, you will catch early the problem of prolactinoma. And it's also important, yeah, in the differential pituitary adenoma, prolactinoma. Okay, I would say increased intracranial pressure can be accompanied also with pseudotumor cerebri, right? So in the differential diagnosis for this patient, what they were looking for, this is what they did. Okay, they were looking for prolactinoma and also the pseudotumor cerebri. They expected in the calibration to hear these two beside any other possible differentials. Okay, who didn't mention that, I
My
think.
question is why she is having blurred vision? Why she's not having a temporal, I mean bitemporal
Okay,
hemianopia?
yeah,
Usually,
this is important. It's great that you raised this point. Don't expect to find everything classic. Read about prolactinoma, and believe or not, you might find that the patient has no problem in the vision at all. And believe or not, the most common headaches that might be associated with prolactinoma is something called cluster-like headache. So the criteria can be like cluster headache, but you will find some other symptoms of prolactinoma. And you need a certain size or specific size, okay, for the compression of the optic chiasma to start to affect the field of vision, and it can
but
cause
why
the
there is
blood
blurred vision? Why
because
there
of
is
the
blurred vision?
papilledema, doctor, because of the papilledema.
Okay.
Patient has papilledema because of the increased intracranial pressure, but the chiasma is not compressed enough to start to cause to affect the field, right?
Yeah.
Okay, so
Yes,
the
yes.
problem is you are expecting to find everything, even in the pseudotumor cerebri. You said, okay, you're going to exclude it just because the patient didn't get weight. Do you know what's the weight of the patient now? What if the patient is already 115 kilos? She's already obese or overweight, right?
Mhm.
Your question was, did you gain any weight? Okay, what if
Mhm.
she's obese? So don't
Mhm.
exclude the diagnosis just because one of the signs or symptoms are not there. You agree with me?
Okay, okay.
Okay, so this is the point. You exclude the diagnosis just because one of the signs or symptoms are not there. Did you ask about galactorrhea in this patient? Did you ask about hair distribution in the body? Did you ask about the lipido, right? All these questions are very important, correct?
Mhm.
Dr. Asana asking what's the second differential. Is it prolactinoma or pituitary adenoma or macroadenoma? And we said it can be pseudotumor cerebri or idiopathic intracranial hypertension. Okay. So now, thank you, Dr. Hannah. With some practicing, this will be solved, inshallah. But I think with these points and sympathy and empathy, I don't want to talk about again. You need to be very sorry for the patient. Your kindness with the patient can um, help the examiner to let you pass the test, you know?
Mhm.
They become very annoyed when you just act like a machine with the patient and just asking question without showing any sympathy and empathy. Okay. So now I will try to be very quick in order to have time to discuss the second case, which is also important and appeared in India and in the UK in the last diet. The headaches, we will take just some time to show everyone the headaches algorithm. Can you please write in the chat box if you know about our headache algorithm? Because I always want to check if we really reach you. If you know about our algorithm of headache, just write yes. If you don't, just write no. So these numbers will help us. Okay. I want to see no's are more or yeses. So it seems like no's. Oh, I have a very bad marketing, right? Okay, because the lecture of headaches is on the YouTube since a long time. Okay, doctor, so now focus with me because headache is very important case, and I always discuss the headaches in the course with the blurring of vision, with the hypertension, with the obstructive sleep apnea, with many of our diagnosis and algorithm. We discuss the headaches, so please focus. It's very important to know the approach of the headaches by heart, okay? So for the headaches, doctor, you will start by asking the patient to describe the pain. And here you will ask for sucrates. I'm sure every one of you know that the severity, the onset, the course, the radiation, what increase it, what decrease it, the timing, and the site as well. Okay. Then you will ask very early about having any visual problem and ask very early about new medication, because who knows, it might be anything hidden in the scenario about any medicine that was recently started. And I'm pretty sure that you know that some medications can cause headaches. Neurotropins can cause headaches. Some antihypertensive can cause headaches. So there might be any new medication that causing the headache. So it's very important to ask this question very early. And when we have a headache case outside, you need to remember this page. Please remember Dr. Tan algorithm for headache when you see that. The first thing is the left side, which is the serious causes of headaches, and the right side are the common cause of headaches. And I just brought the common to remind you. And when we say the serious causes here, you will remember what's called manilbis. Manilbis or malabbis will be the questions or the mnemonic for the question that you will ask, or you remind yourself to ask about the signs of increased intracranial pressure. So the M referred to morning headaches. The L referred to increasing with leaning forward. The B is association with blurring of vision. The N for nausea and neurological symptoms, and the S for sneezing and seizures. Sometimes the patient has headache associated with seizures, and the S for sneezing and cough. So you will ask the patient if this is more in the morning, increasing with leaning forward, associated with blurring of vision, associated of feeling sick or thrown out. Okay, increase with sneezing and cough, if there is any history of fits or seizures. Okay, neurological symptom will ask about any weakness, any difficulty in speaking. So all these are questions that you need to ask to exclude the presence of increased intracranial pressure. Okay, so here, if the answers are yes, and remember, you don't need to have everything answered as yes. It might be only one or two. So you will need to ask about the intracranial pressure. My advice for any case of headache, you need to ask all these questions, and you need also to go to the serious side. You will have good time. Unless you catch it clearly, the diagnosis, you catch it clearly. Please, in the long station, ask everything. The examiners will be very impressed with having you organized that way. Okay, so if you have the signs of the increased intracranial pressure came back positive, you will think about what we call HPTV. HPTV, this is the mnemonic to remind you. The H for the hemorrhage as a cause of headache. So when I'm talking about hemorrhage, let me put the charger of my laptop. Just a second. Okay. So when we talk about hemorrhage, as most of you know, if you attend with me before, that we ask for hemorrhage 4 questions. For hemorrhage, we ask about previous history of hemorrhage, any hemorrhage from other orifice. So patient with, let's say you have a patient with epistaxis, you would ask about motion or bleeding with back passage, for example. So previous history of hemorrhage, other hemorrhages, family history of hemorrhage, and blood thinning medications. So these 4 questions are very important when you want to ask about hemorrhage. Okay, so past medical history of hemorrhage, different hemorrhage, family history of hemorrhage, blood thinning medication. Okay, subarachnoid hemorrhage, the patient will describe it as the worst headache she felt, and it's more acute. Okay, sometimes it's not that acute, but most of the time the patient will come with different presentation other than what we had in this case. And also history of kidney problem because of adult polycystic kidney disease. And I'm pretty sure that this referred to, you know, that it's related to the aneurysm in the brain or ruptured aneurysm in the brain that can cause hemorrhage, which is very common in the patient with adult polycystic kidney disease. So this is what you remember once you have headache to ask about, once you get the answers of increased intracranial pressure positive. The P for pseudotumor cerebri in this case. Okay, so we will, doctor, please focus and then ask your question. I will answer all your questions, but focus not to miss any of what I'm saying now, okay? I will answer, I will go back to all the questions and answer them, so don't worry. For the P pseudotumor cerebri, so remember, pregnancy is a cause of idiopathic increased intracranial pressure, okay? Obesity, okay, which is, it shouldn't be increasing or gaining weight. It can be just the obesity itself, okay? Remember this mnemonic. Hyundai Sonata. I'm sure you know that there is a brand Hyundai Sonata. This will remind you by the question or things, medications related to the pseudotumor. The H for hypervitamin A, okay, which is also the tretinoin, the retin A. It's called retin A. Then the S for steroids, patient on steroids. You need to ask about steroids specifically. The O for oral contraceptive pills. The N for nalidoxic acid. The T for tetracycline. That's why if the patient is taking taking vitamin A or retin A or tretinoin with tetracycline as an antibiotic, they might get this increased intracranial pressure. And amiodarone as well. Amiodarone can cause pseudotumor cerebri, so it is important. Okay, this was a possibility in this patient. The patient is really obese, okay, with irregular menstruation. There might be polycystic ovary disease, okay, with acne. So the patient will treat the acne and the patient will get the headaches for that. So it's and it causes papilledema as well. So it might be the diagnosis. You don't want to reach final diagnosis, but this should be one. If you exclude it just because you are missing one of these, I think this will affect your possibility of passing this case. The T for tumors. And when I say tumor, it can be primary or secondary. So whenever you have tumor, you need to ask the regular question about tumor, which is weight loss, appetite, lumps and bumps, bleeding, specific signs of bleeding. Okay, you can ask about bleeding with back passage, bleeding with waterwork, coughing out of blood. So you need to ask the general questions of bundle 1. And if you didn't attend any lecture with bundle 1, we have a specific bundles to ask in the history for any of these diseases. So you will ask about the general symptoms of tumors and weight loss and loss of appetite. Then here I put it very red because it's very common question in the exam. And it came in 2 centers, this diet. Even with the new system, they still bring the prolactinoma. They like it. So pituitary acromegaly prolactinoma, you will ask about the size of the shoes, the size of the rings. Okay, because the patient might have this as a reason of increased intracranial pressure and different reasons for headaches. Hypertension that happen with acromegaly. Prolactinoma, you need to be very specific about the hair distribution, the cycle, the libido. Okay, sometimes the secretions from the breast, the galactorrhea. Don't ask this question to male about the size of the breast. I mean the secretion of the breast, but you still can ask if you notice any increase in the size of the breast after saying sorry to ask you this question, but did you notice any increase in the size of the breast? Then secondary tumors, so as I told you, it might be cancer that spread to the brain and causing the headache and causing increased intracranial pressure. And for the V, the last one, okay, we said thrombosis here. So what we will be asking about the venous thrombosis specifically, you will ask the 7 questions, actually, not 6 questions of blood clotting. So please write them because you will also ask me again. Previous history of blood clotting. And this also give you the sign that the patient might have some bleeding blood disorder that cause a venous thrombosis, for example, or any type of thrombosis. So previous blood clot, family history of blood clot, heart problem or heart rhythm problem, which include AFib, atrial fibrillation. The 4th question is smoking, oral contraceptive pills, or recreational drugs. So these are the first 4 questions, very important, just write them. You have the bleeding questions and the blood clotting questions. Then basic question, basic diseases, they like it in the exam. So you'll ask about sores in the mouth, sores in the private area, joints pain. It is associated with blood clotting. The other one, and it also came in the exam, not this one, but they like it as well, the paroxysmal nocturnal hemoglobinuria, which is associated with change the urine color in the morning, darkening of the urine color in the morning. Then the 3rd thing, the antiphospholipid syndrome, and you will ask about recurrent abortion, rash, photosensitivity, joints pain, because you know there is overlap with systemic lupus. So you will feel that this question might take time. Just practice that in the front of your mirror. Be organized in this question. It would never take more than 2.5 minutes to ask all these questions about the serious side, including what I will show you now. You will ask about the fever, and my advice, ask about the fever very early, because the fever might give you two causes of serious headaches. And I want you also to draw an arrow, because sometimes with fever you still need to ask about increased intracranial pressure, because the causes of headache with fever also can increase the intracranial pressure. So please write in the chat box what can be the serious causes of headache that will be associated with fever and possible increased intracranial pressure. Please write in the chat box. Think about it and write in the chat box. Any answers there? Okay, meningitis, abscess, I agree. One more I'm waiting for. Okay, abscess. Okay. Okay, meningitis, encephalitis, subarachnoid hemorrhage, TB, tumor. Okay, encephalitis. What else? What else? I'm waiting for something more common. Excellent, excellent. Just stop here. Cavernous sinus thrombosis. Okay, patient with untreated sinusitis or inadequately treated sinusitis, with a history of sinusitis since 15 days without antibiotic, and now developing fever and severe headaches and signs of increased intracranial pressure. This might end up by cavernous sinus thrombosis, okay, which is associated also with fever. So I agree, meningitis, encephalitis, very important. Ask about the job, ask about immunosuppressant, ask about exposure to any sick patient, exposed to more any sick kids, okay, for the meningitis, encephalitis. Other cognition issues and problem, the consciousness affection, okay, loss of consciousness, syncope. All these symptoms are very important whenever you expect fever, okay? Pituitary apoplexy is important as well, and anything in the brain can cause fever, and pituitary apoplexy is also associated, and it is very serious as well, and it is considered emergency, okay? So meningitis, encephalitis, and septic meningitis and thrombosis as well. Then the third thing that you need to ask about early, which is the jaw and skull pain, shoulder stiffness, visual problem, or acute temporal tenderness. And this is for what? For which diagnosis? The genital arteritis.
Temporal arteritis.
Yes. Okay, so this side is very important. You need to know by heart. And if you know it by heart, you will access this patient, this case, very organized, and you would never miss what they are trying to hide inside. Do you agree with me or not? Before moving to the right side, do you find this side helpful? Okay, great. Now let's go to the right side of the algorithm, and you will see the common causes of the headaches, which is common in the exam. And you know, the hemiplegic migraine came many times, and I have one case on our teachable site in the free lecture for hemiplegic migraine. So please watch it. Go to the link of the teachable course and make a count. Just go for the free lectures. You don't need to pay anything. Watch the free lecture because I'm frequently updating these. Again, I want to remind everyone here, we're going to run the course this December 2nd. Okay, so if you're planning to join us, contact Dr. Mahmoud early, because you will receive some materials before the course. So the earlier you join, you will get the materials earlier. So I'm planning to send the materials by middle or the end of this week. So if you're planning, please contact Dr. Mahmoud earlier. So for the migraine can be unilateral and bilateral. Okay, signs and symptoms can be associated with nausea and vomiting, photo and phonophobia, oral contraceptive pills and wine and cheese, alcohol, family history. I'm pretty sure you know that. And remember, for migraine, it can be associated with any neurological symptoms and can even associated with hemiplegia or sign of temporary hemiplegia. So please watch this lecture because it came in the exam. Okay, for the hemiplegic migraine. For the cluster, when we have a case about migraine specifically, I will delve deeper in that migraine. For cluster headache, there is eyes redness, nose stiffness. It happens same times of the day, same time in the year. But as I told you, there is what's called cluster-like headaches, and it is very common to be associated with prolactinoma or pituitary tumors or adenomas. So when you see cluster headaches, don't just assume this is the diagnosis. Please try to ask more questions that might yield more results. Okay, don't be very innocent when you are approaching this case. There might be many hidden issues in the case. Then the tension headache, which is band-like, happening at the end of the day, associated with stress and depression. Okay, and usually it responds to analgesics. Okay, so these are the primary headache causes. We call them the primary headache causes. And for the common causes in the also the other side, remember this mnemonic, which is shukran. Shukran is the mnemonic to remind you what to ask about in approaching a case of headache. And thanks God, with 15 minutes, you will be able to ask what you want if you didn't catch anything. So the S referred to, please write, capture the screen. It's okay to capture the screen. Please capture it. And remember to write these, because if you don't, you will forget what I was talking about. So the S for systemic lupus. Systemic lupus is associated with headache, and you will ask the screening question for systemic lupus, including photosensitivity, joints pain, frothy urine. Okay, so these questions you need to ask about hand pain. You need systemic lupus. This is one. The other one is sinusitis, as I told you, the forehead pain, history of sinusitis, recent infection, fever, the quality and the character of the breathing and the headache itself. So the S for systemic lupus and sinusitis. The H for three things: hypertension, hypotension, hyperviscosity. And you will also find in Teachable one case for the polycythemia rubra vera, which also came in the exam. And you will see a slide there about what to examine, how to ask about polycythemia rubra vera. Okay, so hyperviscosity with the criteria of itching, with the plethoric phase, congested phase, the character of headaches. It's very important to remember the hyperviscosity as well. The O for obstructive sleep apnea. Obstructive sleep apnea, very common, and I know for anyone who attended with me now, you know it by heart. You have 4 symptoms all over the day, and you have 3 things to examine. The 4 things throughout the day is something in the morning, which is morning headache and unfreshness. Something during the day, which is feeling tiredness and sleeping during watching TV or driving. Something before sleeping, which is loss of libido or erectile dysfunction for males. And something during sleeping, which is gasping for air, okay, and attacks of apnea. So these are the main 4 symptoms of obstructive sleep apnea. You can add to that uncontrolled diabetes, uncontrolled hypertension, weight gain, all this, okay? But these are the main 4 questions for obstructive sleep apnea. And what you will examine the oral cavity for any NT abnormality. You will check the neck circumference, and you will check the lung or the chest for pulmonary hypertension signs. This is the obstructive sleep apnea. So congratulations. If you know that, there is a good chance to pass the obstructive sleep apnea question with a full mark. The C refers to CO poisoning, which I have one case about. So you need to ask if the patient's house or a working area is well ventilated. You need to check what's the patient job, if he's exposed to CO, if the patient using burning fuel at home, if the patient recently moved to new home or changed his job. So it's very important to ask these questions in order to catch what's hidden. And if you also watch my YouTube, there might be a lecture about something related to that very interesting case. The R for refraction problems, it might be that easy. You excluded everything and it's just refraction. The patient need eyeglasses, because we are teaching that not only for the PACEs, for your usual life, for the approach of headaches. So you don't need to be very suspicious for everything. It might be only refraction. So common is common, and easy things comes first. Then the A for analgesic induced headaches, and you will be surprised when you know more details about that, because the amount of medication or medicine needed to achieve that is very funny. I think if we follow these numbers, we will all have the analgesic induced. But believe it or not, maybe 1 week of paracetamol is enough to call it analgesic induced, sometimes 15. For the opioid, maybe 5 days. I can't remember the number exactly, but anyway, It's funny to know that it's that easy, but this is a diagnosis by exclusion. So please, after excluding everything, you can put it in your differential. Don't just jump and say, okay, it's analgesic induced, because you will expect everyone with headache to come to you with a history of taking analgesics for a long period. So please don't take it easy and say, okay, it's analgesic induced headache. It doesn't work that way. Then the last is the N for the neuralgia, trigeminal neuralgia, and it's always very abrupt pain, and it's very severe. It might need treatment with anti-epileptics like carbamazepine. It starts suddenly, abrupt start, and it ends suddenly. The patient had the pain, crying, 2 minutes, then it disappeared. And for that, we give carbamazepine. Okay? So this is the general scheme for the headaches. You can add anything to that, but when you have this in your mind, your approach to the headache patient in your clinic, in your life, in your PACES exam will be definitely better. Okay? Give me now the okay in the chat box that you learned something from this algorithm, and if you really learn from this algorithm. This algorithm
Doctor,
will make you way more confident when approaching this case. Yes, doctor.
Doctor, I have one request.
Mm-hmm.
Just
Go
to
ahead.
know just to correct myself, I want to take maximum benefit today from your lecture. I just want you, if you would be at my place and I will be the surrogate, and same scenario, you take the history, and I want to know how you go it, because this is, for me, this is the biggest problem. If I fulfill all the criteria starting from family history, and this family history, drug history, social history, everything, then I just want to know how we can finish it in 7 to 8 minutes, so that there should be an ample time for examination.
Yes, we definitely can do that. You mean I will be the candidate and you will be the surrogate, right? This is what you
Yes, same
said?
scenario that you have given me, I
Okay.
will
What
do.
about doing that after the lecture through the WhatsApp in order to go to the next case? And I promise to help you with that once we finish.
Okay, no
If
problem.
you
I
then
will.
just contact me on the WhatsApp. I will do the case with you. We can practice it together. Okay. And they will show you exactly how I can ask all these questions in 6 minutes.
Okay.
But remember, when I catch the what you have in this case in the left side, I won't go and ask all these questions on the right side unless I have enough time. You know what I mean?
Yes, I know, but even then, if we want to do the past medical, surgical history, drug history, family
Yeah,
history,
that's
social
why,
history.
doctor, that's why I'm telling you, you don't need to go to the whole right side. If you catch something in the left side, with this
Huh.
patient, you catch the prolactinoma and you catch the pseudotumor cerebri. So two things are hidden there for a reason, right? Then you
Mhm.
catch something. You can build on these, and then you'll stop there and start asking the social, ministerial, family, travel, and all this
Mhm.
stuff. So you need to learn
Because it
what
takes
to
three
omit.
minutes to complete this family, social, medical, drugs. It usually takes.
It
I
takes two
practice
minutes.
my.
Yeah, I will help you with that. I mean, I will show you if I found that you are like expanding your question, I'll show you how to do that. So don't worry. It's more with the 15 minutes in the new system. Don't worry, you have enough time. Believe me. You just extended your question. Believe me. Okay, don't worry. Okay, just contact
Okay.
me on WhatsApp once we finish. Okay. So now, doctors, I want to know what do you think about the algorithm? Do you think it's helpful? Please write that, then we will go to the next case. Tell me if you feel more confident with the headache cases if you have this approach in your brain. And Dr. Rufaida, only
Yes,
three, only 3 out of 10 found, out of 100 found that helpful. Okay, great. Thank you, doctors. I'm just asking for that to check that you really know that before. Please, doctor, not for my lectures only. If you have any free resources, please watch it. I mean, check my channel on YouTube, check any other doctor channel, any other tutor channel, and watch the lectures. This will help you. Even if you won't attend any of our courses, there are free resources, so watch them. It might be the reason for passing the test, okay? So when I see I have these videos since 6-7 years on the internet and you didn't watch it, so I'm sure you didn't search enough about the resources for your preparation, okay? So please, when you have anything free, I have also on the Teachable, as I told you, in the link I will share with all of you now, in the link of Teachable, just make an account, you won't pay anything, okay, and watch free lecture. I'm updating regularly. So whenever there is a free lecture there, just watch it. You won't pay anything, okay? Okay, again, if you want to join our interactive course, I run the interactive course twice a year only. So it's one now and maybe one in May. Okay, so if you're planning to join, please contact Dr. Mahmoud as soon as you can to receive the materials, the pre-course materials. Dr. Rufaida. Dr. Rufaida, this patient that we will discuss now, this case came in Chennai, Diet 3. So it was one of the 2 communication cases that appeared in the last exam. And it is interesting. So please, no one, don't leave, because this case is not easy. I mean, if you see it for the first time, you will miss a lot of things. But before starting the communication, what I always say in the communication, your mission is to be kind. Your mission is to use your weapons, okay, to convince the patient and mitigate the situation. So you are not in the mission of showing the examiner some data, you know. You are in the mission in convincing the patient that his problem can be solved by us as a medical team, or to support the patient feeling or help the worries of the patient. So please, please, please don't act as a machine with any communication case. And if you missed our last week lecture, I shared on our Telegram group. So please watch it, because the 2 cases we discussed also appeared in the last diet. So please don't miss the other 2 cases. I shared the record and it will be closed after 2 days, because I put the share for 5 days only. So please watch them as well, because these 2 cases also appear in the exam. And if you didn't see it before, you might miss it if you find it in the front view. So Dr. Rufaida, you are the doctor in neurological clinic, and you are a neurologist conducting a follow-up appointment with Ms. Smith. She's the 32-year-old patient who has been diagnosed with epilepsy for 3 years. Mrs. Smith has been taking lamotrigine for seizures control. Today, she expresses concerns about her inability to conceive. Again, it's related to the other case. After trying for 1 year, okay, she's trying to conceive since 1 year, and she believes that lamotrigine might be the cause. She is considering stopping the medication in hope of improving her chance of getting pregnant. Let me know in the chat box. Did you hear about this case? Did you hear it? Did you see that many of the candidates were like confused if they did this case well or not?
No, at all.
Yeah, because no, it came in Chennai, and I got many questions about that. They were asking like, what should we say? Should we change it? What if we don't know if lamotrigine is appropriate or not? So it was a good case, and we will discuss it in detail. I'm pretty sure that you will learn a lot of things. So, doctor, I will give you 2 minutes, and please, when I come back, remind me to resume recording. I will give you 2 minutes to prepare, unless you're ready to start. You want to start, or you need 2 minutes?
No, I can take 2 minutes, please.
Okay.
Yes, I am Irish candidate, and still now I did register for my exam. I think maybe it is in the next March or February, if they accept it.
Okay, great. Good luck, inshallah.
Thank you for your helping.
Thank you. So you have 10 minutes, doctor.
How many minutes?
10 minutes. For us, it's 10 minutes. Now you have 2 cases in the MRCB UK. So you have 2 cases. Each case is 10 minutes without examiner's question.
Okay.
Okay. So you have 10 minutes with the patient to talk about her concern. And remember, use all your weapons. So hopefully you wrote what you're going to talk about and how you are going to convince. Assume this patient is yours in your clinic, and this is exactly what she's telling you. Forget that it is exam. This is what you have in the front of you in the office today. Act as a real doctor, okay?
I hope if I can.
You will be able to do. I know you do that every day, so I'm pretty sure you will do great, okay?
I will try.
Okay, start.
Hello,
Hello.
my name is Dr. Idris. I'm the doctor in the nerve clinic today. I am speak with Mrs. Smith, 32 years old.
Yes, doctor, that's me.
Nice to meet you, Mrs. Smith. Mrs. Smith, we are here to discuss issue related to your health status. It is okay with you?
Yes, sure, doctor.
So do you need anyone to attend our meeting today?
No, doctor, I'm good.
Okay, so Mrs. Smith, how much you know about your condition?
How much I know? I have diagnosed by epilepsy because I got many seizures and fits 3 years ago, and I started on different medications, and then eventually they keep me on this medication I'm currently taking. But I start to be very worried about my ability to become pregnant, and I think this medication might be the cause for that. And we start to be very annoyed and worried about our ability to, age is going. So I will stop it for now until they find something to help me, because I really want to have a baby.
Okay, Mrs. Smith, I appreciated your knowledge about your health, but I think there is misunderstanding. If you allow me, I can explain that for you. And be sure we are here to help you, and all we are here to supporting you, and we can do our best to helping you, okay? So any expectation or idea about what is going on, Mrs. Smith?
What's what?
Any idea or expectation about what is going on?
No, as I told you, doctor, nothing new I can add.
Okay, so Mrs. Smith, I'm really so sorry about what you're passing through. And based on what you told me, I know that you are suffering a lot with this, with your epilepsy, and I'm really so sorry about that. And be sure we are helping you. And also, you mentioned for me that you are stop this medicine after it is control your jerky movement.
I lost you, doctor. I can't hear you. What you said in the last thing? No, the line is breaking.
So it's based on what you are.
Dr. Faida. No. Dr. Faida, give me a second. Give me a second. I can't hear you well. So I stopped the time. Just resume what you said. The last thing you were asking about my expectation, right? And then start from there after my expectation. Hello?
So
Doctors, is that my connection or Dr. Faida connection? Can you hear my voice clear, or my voice is breaking as well?
Yes, we can listen, sir. Your voice.
My voice is clear?
Yes, your voice clear.
sorry,
Okay, so
I am lost.
okay.
Okay,
So
so now
Dr.
you
Faida,
heard me well? Now you heard me well?
yeah, now it's okay. Now it's okay. Let's start from, I stopped the timer. So let's start again from, you asked me about my expectations, and I told you that what I told you, okay? So I don't have a specific expectation for the meeting. I'm going to stop the lamotrigine anyway, okay? Because making a baby is more important to me than anything else. Okay, you can start from here.
Okay. And Mrs. Smith, I'm really so sorry about what you are passing through. And be sure we are here to helping you and we are here to supporting you. And I know how much that you get the baby is something important for you. But if you allow me, also I can explain for you more. Are you with me, Mrs. Smith?
Yes.
Okay. So, Mrs. Smith, you told me you are suffering in the previous 3 years, and regarding this jerky movement, and fortunately, this lamotrigine now it is controlling your symptom. I'm right.
Yes.
So, which is something good, Mrs. Smith, and that exactly what we are wanted. So, and now you are stopped just because you are. I mean, you are stopped because you want a baby. I'm right.
Yes.
Okay, I highly appreciated what you are feeling, Mrs. Smith, but I reassure you, and this lamotrigine had no any relation to that, to getting baby. And most important for us, when you are stop this medication, the health it will be deteriorated, Mrs. Smith. I'm really so sorry
You
about.
said no connection, doctor. Is that what you're telling me? So lamotrigine or this medicine cannot affect my ability to get a baby?
Yes, Mrs. Smith, but don't worry, even we can make another meeting with a woman doctor and can help you a lot about this issue. And now the most important for us here to control your disease, which is something important even in case of you if you want to get pregnant, Mrs. Smith. Are you with me in this point?
Yes.
Okay. Mrs. Smith, this, as you know, that you need for me to explain more about how this epilepsy.
How what? No, I know enough about that. I read a lot about the epilepsy. My point
Okay.
is I don't, because my sisters, they all have kids and we don't have any problem in the family. The only thing I'm doing that is different is taking this medication. So I'm pretty sure it might be the cause for delaying my ability to have a baby or to become pregnant.
Okay, I highly appreciated your concern, Mrs. Smith, and I understand your worry. But I reassure you again, this is had no relation with that one. And now, meanwhile, we need from you to continue on medication until we make a meeting with a woman doctor. She will be able more to give me a more information about that. But meanwhile, I want from you to don't put yourself in a danger. Are you with me, Mrs. Smith?
Yes, doctor.
Okay.
I'm really not worried about myself as I'm worried about my husband, who's very upset that we can't make a baby. I'm 32 now. I don't want to lose the chance.
Oh, Mrs. Smith, I'm really with my heart with you. Don't worry about this issue, Mrs. Smith. And if you are not worried about your health, how we are worried about your health more, Mrs. Smith. And you know, if you are not taking care about yourself, even if you get a pregnant and you get a baby, how you can grow this baby? So my advice for you, Mrs. Smith, I know you're worried and I know how much you want to get a baby. And I reassure you, don't worry about this issue. We are involved, the woman doctor, she can help you a lot about this issue. But meanwhile, really, I want from you to resume your medication, Mrs. Smith, for your health. Do you know, can you allow me to explain for you what's happened if you are not take your medicine, please?
Okay. What will happen?
Okay. I'm really so sorry to tell you that, but you should know about everything, Mrs. Smith. This is my right, okay? So I'm really so sorry. First of all, if this jerky movement coming again for you and continuous for you, it can damage your brain. I'm really so sorry about this bad news, okay? And even during this jerky movement, it can some of the food sometimes it can go through to your food pipe, through, through to your air pipe, and this is also can affect your lung and can affect your respiration, Mrs. Smith, which is something dangerous, Mrs. Smith. Are you with me?
Yes, I'm with you and start to be very scary. I feel that you're like confronting me.
I'm really so sorry about that, but you should be aware about what happened exactly if you are stop this medication. your health will be in danger. And even this jerky movement can happen at any time and at any place, even when you are driving, and this can lead to car accident. I'm really so sorry about this. That is why I'm worried about your health, Mrs. Smith.
Yes, doctor, but I didn't
And
get any fits since 3 years.
sorry, you
So
didn't get what?
maybe I didn't get any fits in the last 3 years. So maybe I'm
Yeah.
already cured, right?
I highly appreciated your concern, and I like your question so much, Mrs. Smith. But as you tell me, this is happened because you are
2
controlled
minutes
already.
remaining, doctor.
Okay, this is already happened because you are controlled with this medicine, and I am afraid whenever you are stop this medicine, the jerky movement coming again for you, and your life will be in danger. So,
So
in the
I will
best
still
of
on
interest,
this medicine forever?
I highly appreciated this one, and we are making another meeting with my consultant, and then we assess your condition more. And this time also, I can involve the women doctor. She can join with us and help us regarding the issue. It is okay with you now, Mrs. Smith?
I still don't feel comfortable to stay on this medicine, doctor. And I don't believe it is not related to my inability to conceive.
Okay, I highly appreciated this also, Mrs. Smith. And don't worry about that. I can make another meeting with you and my consultant also. And with the women doctor, they can sit with you and they give you more information which can help you more than me. It is okay with you, Mrs. Smith? But meanwhile, please, Mrs. Smith, I have some advice for you. Please try to take this medicine. And if you are not want to take this medicine, this is my the first advice. Second advice, you should take this medicine. Second advice, whenever you are go, some person should go with you, because as I told you, the fit can happen at any time and your life will be in danger. I'm really so sorry about this news, Mrs. Smith, but this is your right. You should know that, Mrs. Smith. I'm really so sorry again. Are you with me?
Yes. Yes, doctor.
Okay. Okay, so still you are not convincing to resume your medicine, Mrs. Smith?
I will think about it, doctor.
Okay, I highly appreciate this from your side, Mrs. Smith. So can I ask you some social question, please?
Okay. Time finished.
Okay.
Okay. Okay, thank you, Dr. Rufaida.
Thank you.
Did you feel a little stressed or something?
A lot, actually. I didn't even know how I can handle this.
Yeah. Again, when you are in this, that's why practicing is important. Even if you are like watching lectures only, please practice with your friends, or even at least practice in the front of the mirror or something. You need to practice the case yourself, not you specifically, I mean everyone. But let me start by telling you that you did very well, and I would say the strength points. You did very good. You raised some great points in your scenario. Your sympathy and empathy were great. Following the understanding and that the patient is following you also was great. You didn't pay much attention to the scenario itself, and it is important because you don't know if I stop the medicine or if I'm planning to stop the medicine. If you read the scenario, she is considering stopping the medication, and you were talking as if she already stopped it. You agree with me? So you can just ask the question if you stop the medicine, if you are planning to stop the medicine, because you need to know it's different in what you're going to do, right?
Yes, you are right.
Okay, so I mean the point that you will get from that you need to be very clear in what you read in the scenario, because if the examiner won't talk to you, you might build your argument on a wrong statement. So in different cases, not in this specifically, but in general, be careful to read the scenario very well. Okay, and the other thing, you didn't ask me if my epilepsy is controlled already. I mean, you don't take history, but it is a weapon that you will use, right? If the patient has the last fit 3 months ago, is it the same if the last fit was 3 years ago? Is it the same? Don't you think that can give you a strength point? If the
Yes, it
patient
can help
has a
you a lot.
frequent fit or something, exactly. So you won't go in details of history. It is not, you shouldn't take history in communication, but you can just ask it as a quick question. I don't know if your seizures is in a full control, but when was your last seizures or fits? Because her concern about 3 years, this will give an answer for something. The patient after 3 years without fits, don't you think, okay, with the fits in since 3 years, sometimes we evaluate stopping the medication or lowering the dose? Don't you think this is something that we consider?
Yes, after 2 years from fits free, we need to evaluate the patient again regarding stop
okay.
harm.
So don't you think explaining that to the patient also will mitigate and convince her to wait and not to hurry up and stopping the medicine? That with having no fits in the last 3 years, we might consider lowering the dose or even stop it, but this can't be done abruptly because this can increase the charge and the electricity in your brain suddenly, and it will put you at risk, right? So there is a way to stop these type of medications, and you might need brain tracing before making this decision. Our team will make this decision and help you with that if you don't want to continue in the medication. But I want to reassure you that lamotrigine is not directly related. One of the things that I didn't like that you were like very confident in answering that lamotrigine is not related to fertility, although this is true. But if the medicine is medicine X that you don't know the answer, okay? I don't want you to be like confirming a clinical information that you might not sure about it, right? Because you might be wrong. So just tell her that lamotrigine is, because you know that lamotrigine is okay with pregnancy. So lamotrigine is known not to be related to the ability to conceive or to make a baby or to become pregnant, but we still can review with the consultant if he can consider any other medication if you really don't want to continue on this medicine. But this should be done under the supervision of the medical team after brain tracing and blah, blah, blah. And also with the arrangement with the woman doctor, exactly as what you said. Okay, they can together decide what can be the best approach of continuing your treatment and raising your chance of making a baby. And remember that there might be many other causes and reasons for inability to making a baby or to become pregnant, right? And all these can be like evaluated better with the woman doctor. I can help you with arranging this appointment. You agree with me?
Yes, I agree.
So the idea, Dr. Rafaida, is you write outside in the 5 minutes your weapons. So if you write outside, yes, lamotrigine, I will talk about that lamotrigine is safe. Let's say this is one of the weapons. I will talk about the risks of stopping the lamotrigine. I will talk about the other possible alternatives. I will also know more about her social history because she might be at risk. She is a swimming trainer. Okay, you didn't ask that. So she might put her at a great risk. I like very much the point that you raised about her ability to take care of the kid and even to tolerate the pregnancy. Do you agree with me? What if you become pregnant and she got like more fits? This is very risky for herself and for her pregnancy, right? So I like when you raise this point as well. Okay, what else I wrote here? Yes, you were talking like you are the consultant of the neurology. So you will be the senior registrar or the senior house officer in the neurology clinic. And so always include the consultant. So say with the arrangement between the nerve consultant and the woman consultant, we can put the best management plan for your condition. Right? So don't talk like you are the end of the line in your specialty because you are not a consultant. This might be a little irritating to the examiners, okay? But overall, you did a great job. You used the great weapons. And I am satisfied with what you did. And for the question, doctor, asking me in case you don't know lamotrigine safety, what can be my approach? If you don't know, you will, as I told you, doctor, if you don't know if it is safe or not, you will be talking about that we shouldn't stop any anti-fits or anti-seizures medication abruptly, and you will explain that this medication is controlling the charges and the electrical charges in your head, and if we stop any medication abruptly, this might put you at risk or very high risk of having the fits happening again. Okay, this should be stopped gradually. So you will go with the problem with stopping the medication, and you will mention that with the consultant, we will discuss if there might be a better option. But for now, please don't abruptly stop the medication by your own. We stop this medication if there is allergy or there is something that's really urgent that we need to stop it, but we need to consider also brain tracing, and we might consider safer alternatives, but this will be done through the medical team. The question?
Thank you so much for the chance, Dr.
I have another question, Doctor. Sorry, just a question. The task of this task was not clear in this communication topic. Usually, my understanding in PACES, they will tell you the task exactly what you should discuss with the surrogate. But here, I didn't know exactly what is the task that I should discuss with the surrogate.
Yeah, you can just see, right, discuss her concerns. Because it's clear that she wants to stop her lamotrigine. Let's say we are in the real life and you got Mrs. X, and she came and she told the nurse, I'm going to stop the lamotrigine, or she called and said, I'm going to stop this lamotrigine because I want to become pregnant. And your job is very clear that you want to advise her not to stop the medication abruptly because the risk will be 1, 2, 3, and you want to reassure her that this medicine is not the reason and she should be followed by the woman doctor. So I don't think you need more. They won't give you like a clear clarification when the scenario is that clear. There is nothing hidden in the scenario. Because, I mean, by intuition, you will understand that your mission is to convince her not to abruptly stop the medicine, right? And to reassure her that lamotrigine might not be the cause of infertility. You got the point?
Okay, thank you so much. Yes, thank you so much. Thank you.
Thank you, Doctor. So you will see in this slide that we will address Mrs. Smith's fertility concern with sympathy and empathy, and you did that, doctor. Emphasize the importance of stable epilepsy control for overall health. Just, Dr. Rufaida, be careful, don't confront the patient. Confrontation is very annoying to the examiner. So don't keep frightening her. You might die, you might have an accident and kill everyone in your car. I mean, don't be very aggressive in describing the risks, but it's a very important weapon, and you did that in a great way. But be careful not to confront the patient much, because some patients become very anxious and said, okay, doctor, you made me very terrific and very, anxious about or scary about my condition. Okay, so try to be like, don't confront the patient that much or threatening her. Maybe if she did this, that will happen. Provide education on lamotrigine and its role in epilepsy management. If you spend 3 years without having any fits or seizures, this means this medicine is a great selection for your condition. And it might be, if we change you to a different medication, there might be a good choice, and your controlled condition might become uncontrolled. So we shouldn't just look for the possibility of side effect, which is not true with lamotrigine, but we need also to check how this medication is helping us now. One thing about the lamotrigine, we don't stop it with the pregnancy, but we advise always the patient, any pregnant, folic acid. So if this piece of information, if you know it, it won't be a bad idea to mention that some medications, sorry, I think my connection is unstable again. Just a second. Okay, so if you know this piece of information, or in general, you will mention that some medications, some fits medication or seizures medications or anti-seizures medications are not safe with the pregnancy, and we need to consider avoiding become pregnant while taking them because they might affect you and affect the baby. But lamotrigine is not one of these, although there are some advices that you need to follow and ask your woman doctor about, such as the need to take what's called folic acid 3 months before the pregnancy. And even if you didn't start it yet and you become pregnant, you still need to start it as soon as you can. So this piece of information will show the examiner that you're knowledgeable, and the patient will feel more confident about your information. But if you don't know, no problem. But in case you got the same case in your exam, This will be very helpful. Then suggest a collaborative approach with fertility specialists for a comprehensive assessment. Discuss the need for coordination decision-making with all the team and with the neurology for medication change, and ensure her about being supported, and she is part. We are not going to continue any medication that you are not happy with. So Dr. Rufaida, some tiny stuff is important to the examiner, which is reassuring the patient that if the patient has the autonomy to refuse the medicine. Let's say the patient decided and insisting not to take the medicine, we might need to give her an alternative, right? But she needs to know that it's part of her rights to know that you can refuse the medicine, even if it is the best thing for your condition. So just keep these points in your mind beside what you discussed. Eventually, you will get a full mark if you didn't miss any of these. Okay. The last thing will be for today, which is very important. It's related to this case, which is non-compliant. We can consider this case non-compliance. Okay, because when we talk about non-compliance, we need to ask the reason, the seriousness, the alternative, and the help. If you remember Risala for patient refusing medication or refusing procedure, we just remove the L of Risala. So you have the Riza, which is reason why you want to stop the lamotrigine. In this case, she described that it's about the possibility of infertility that can be caused by it, which is not true. But this is what she thinks. She might read something that any anti-epileptic medication can affect the fertility. Okay, the seriousness. What I mean by the seriousness is what I told you, be careful, don't confront the patient. So what does expect her condition? So if you ask her that question, what do you think if you stop this medication might be the consequences? What do you think? Let her say that by herself. She might say, yes, okay, there might be a risk that I will get the fits again. Yes, so ask her the question. What do you think? What do you expect your condition will be without taking this medicine? And if she give incorrect answer, correct her answer if you can. Do you know the risks of not taking the medication or not doing the procedure, depending on what's the scenario? Don't confront your patient or threatening them. Always keep yourself calm and polite. Don't show the patient that he is or she is stupid, okay? Don't show them, okay, this is crazy to stop the medicine. No, just respect their willingness to do what they want about their health, even if they want to die. It's their choice. People not taking important medication could endanger their lives. So asking about her job and the risks in driving and all this stuff is important. Even if you will not threatening the patient, you can just mention something about, do you drive? Do you know that there is a risk to your ability to drive with having any fits will be affected? Okay, because you know some patients, after controlling their epilepsy and spending a long time without fits, they get allowed to redrive, right? Or resume driving. Then alternative, be very careful about alternatives. I don't want you to just assume that you can give any alternative. Your consultant will be the one. If the consultant wants you just to give another medication, they won't send you. Okay, they will allow the patient to change the medication without sending you. So remember, alternative sometimes is describing why alternative won't be appropriate. So in this case, I can say something like, you know, we have a limited choices of medications for the fits that can be taken with pregnancy, and lamotrigine is one of them. So this is also convincing point, right? So, and other alternatives can be harmful to your pregnancy, even if you think they might give you a better chance of becoming pregnant, which I doubt. Okay, they might be affecting your pregnancy or the baby. So if the patient refusing colonoscopy and want a CT instead, you will mention that the CT won't allow us to get a SNP if we found any mass or remove any growth like the polyps. So in the alternative, it is not offering alternative, it's more explaining why the alternatives won't be enough compared to what we are offering. But sometimes you can offer a smart alternative. So if the patient is refusing taking tablets, taking metformin, which is like rapid release metformin because of gastric upset and the compliance, you might offer extended release. You know what I mean? If the patient refusing to take the insulin in her arm, you can offer having a pin instead of the syringe, the injection pin. So sometimes you can offer alternative if you are not going to change the consultant or the management plan itself. You got the point? Please let me know in the chat box that you're still awake, because I feel I'm talking to myself. Then the last thing is the help, which is always include the GB, include the psychiatrist, offer the patient. I'm going to give you a YouTube links and internet links or brochure about the lamotrigine, and this might reassure you and make you more relieved about taking the medication. And they also will give you a link for groups that discussing these issues together, and this might help you very much. Do you have any question at this point? To me, this is your question to it. So when you feel when the patient feels that you covered all these, they will say, no, thank you, I will rethink about it. And you can confirm by, do you still thinking or planning to stop the medication? No, I will postpone it until I meet the blah, blah, blah. So thank you. So you did your job, you got the full mark, and you move to the next case, right? So this is called the non-compliant as part of our communication course as well. And let me see if I put the other slide of that. Just a second, please. For non-compliance, I don't have them here, but I always have like more details about the non-compliance during our course, about all the condition. Patient refusing taking steroids, patient refusing doing upper GI, patient refusing NGT. All these type of non-compliance will be discussed during our interactive and recorded course. Okay, just one thing before I leave, please, if you are planning to join our course, do that early, our interactive course, because I only have 2 in the year. This one we will start December 2nd. So if you're planning, don't surprise me just 1 day before the course, because I want everyone to be on the same page. So I'm making account on Teachable for you, and you can watch your lectures inside, some stuff you need to prepare before we start. Okay. Okay, now please let me know if you learned something. And these are the links for our WhatsApp, Telegram. Join our Telegram and WhatsApp for the free lecture announcement. And watch the record of the previous lecture. I put it on the group, on the Telegram group. So please watch it, because the cases were live. I want you to watch all the recent cases, because, you know, with the new system, they might need to repeat many cases. So please don't miss any case we practice. Maybe at least we will get your dua if you found any of these inside your station, right? You learned something today. Hopefully you did. Enjoy preparing for PACES. Feel free to contact my phone number. You will see my phone number and Dr. Mahmoud's phone number on the top of this. I'm sharing with you 100 times, so you can just keep my number and contact me for any question. Without the course, without anything, I'm ready to help anyone. The course is extra because it's 12 days with 5 hours a day divided on 3 weeks. So not everyone is ready to take that, but it's very helpful. It will make you very much prepared. But I will keep answering your question. I will keep sharing things on my groups to help you, inshallah, to clear this exam. Okay? Thank you. Okay, Dr. Hanna, okay, contact me on the WhatsApp to discuss what you asked about.
Okay,
Have a
thank
wonderful
you.
day. Assalamu alaikum.
Right now?
Yeah, right now.
Okay.
Assalamu alaikum wa rahmatullahi wa barakatuh.